Good morning. Today we will be discussing the topic shock. Shock will be discussed under following subheadings: definition, classification, pathogenesis of shock, stages of shock, morphological features, clinical features, and complications. By definition, shock is a circulatory disturbance, and it is a state in which diminished cardiac output or reduced effective circulating blood volume impairs tissue perfusion and leads to cellular hypoxia. Coming to the classification and etiology, shock is classified according to its cause, and it is generally classified into hypovolemic shock, cardiogenic shock, septic shock, and others include traumatic shock, neurogenic shock, hypoadrenal shock, and anaphylactic shock. Hypovolemic shock. It occurs due to inadequate circulating blood volume, which can be due to acute hemorrhage or bleeding, dehydration, burns, and excessive use of diuretics. Cardiogenic shock. It occurs due to acute circulatory failure due to sudden fall in cardiac output from diseases of heart. This can be due to deficient emptying, like that in myocardial infarction, cardiomyopathies, cardiac arrhythmias, deficient filling of heart, as in cardiac tamponade, and outflow obstructions, like in pulmonary embolism and ball valve thrombus. Septic shock occurs in severe septicemia or bacterial infections. It usually occurs in gram-negative bacterial infections, which is known as endotoxic shock, and less commonly it can be seen in gram-positive bacterial infection, which is called exotoxic shock. Traumatic shock occurs in severe injuries during surgery and obstetrical trauma. Neurogenic shock occurs due to interruption of sympathetic vasomotor supply, as in high cervical spinal cord injury, high spinal anesthesia, and severe head injury. Hypoadrenal shock occurs due to adrenal insufficiency, while anaphylactic shock occurs in anaphylaxis, which is an Ig-mediated hypersensitivity type 1 hypersensitivity reaction. Now coming to pathogenesis of shock. The pathogenesis involve three derangements. First of all, there is reduced effective circulatory blood volume, which leads to reduced supply of blood or oxygen to the cells and tissues, which in turn will cause cell injury and release of inflammatory mediators and toxins. So the cycle is like this. Reduced effective circulatory volume causes impaired tissue oxygenation and tissue anoxia, which will cause cellular injury. The cellular injury will activate our innate immune system, which will release inflammatory mediators from monocytes and macrophages, which will exaggerate the cellular injury. And this will go on like a vicious cycle. Pathogenesis of hypovolemic shock. As we know, it occurs due to decrease in circulatory blood volume due to severe bleeding, dehydration, etc., which will cause decreased cardiac output and in turn will lead to decreased tissue perfusion. And also it can lead to low intracardiac pressure. The severity depends on the amount of blood loss. For example, less than 1000 ml of blood loss can be compensated and usually won't go to shock, while loss of more than 200 ml of blood can lead to severe shock. Coming to the pathogenesis of cardiac shock or cardiogenic shock. Here there is decreased cardiac output due to disease of heart, which will lead to decreased tissue perfusion. And also Since the heart is not pumping out blood as usual, there will be movement of blood from the pulmonary vessels to the interstitium, which will lead to pulmonary edema. Coming to the pathogenesis of septic shock, as we know, septic shock usually occurs due to the infection by gram-negative bacteria, which will lead to activation of macrophage monocyte system. That is, the lysis of bacteria in our body will release endotoxin, which is a lipopolysaccharide. This will bind to lipopolysaccharide binding protein present in our blood. And this complex, that is the lipopolysaccharide, which has bound to LBP, binds to the CD14 on monocytes and macrophages, which in turn will lead to the release of pro-inflammatory cytokines from these cells, which includes mainly tumor necrosis factor and interleukin 1. The pro-inflammatory cytokines tend to alter the endothelial cell adhesiveness and will recruit neutrophils, which will in turn release free radicals, which will cause vascular injury. Also, it promotes in situ nitric oxide synthase, which will in turn cause vasodilatation and hypotension. In addition to this, there will be activation of other systems like activation of complement pathway, which will produce C5a and C3a, which will cause formation of microemboli and endothelial damage, activation of mast cells, which will cause release of histamine, which in turn will increase the capillary permeability. There will be activation of coagulation system, which enhance thrombi formation within the vessels. And there will be activation of kinin system, which will release bradykinin, which will cause vasodilatation and increased vascular permeability. All these in turn will cause hypotension or will decrease the effective circulatory blood volume in our system. Now coming to stages of shock. It can be divided into compensated shock, progressive decompensated shock, and irreversible decompensated shock. Compensated shock. It is the early stage of shock in which the shock is non-progressive and reversible. Our body will attempt to maintain adequate blood supply to vital organs like brain and heart. There will be activation of neurohormonal mechanism causing widespread vasoconstriction, fluid conservation by kidney, and stimulation of adrenal medulla to release catecholamines. Clinically, the patient will be presenting with tachycardia and cold clammy skin, and we can bring about recovery and establish normal circulation. Progressive decompensated shock. The patient suffers from some other stress or risk factors like pre-existing cardiovascular or lung disease besides the persistence of shock. There will be progressive deterioration of the patient's condition. There will be pulmonary hypoperfusion and a tissue ischemia. In pulmonary hypoperfusion, the pulmonary perfusion is worsened with increased in vascular permeability, leading to tachypnea and acute respiratory distress syndrome. The tissue ischemia leads to anaerobic glycolysis, leading to lactic acidosis, which in turn will lead to vasodilatation and peripheral pooling of blood. There will be decreased cardiac output, mental confusion, decreased urinary output, and tachypnea in patients. Coming to irreversible decompensated shock. Here, the shock is severe that in spite of compensatory mechanisms and therapy and control of causative agent, no recovery takes place. There will be widespread cell injury, which will lead to progressive vasodilatation with peripheral pooling of blood and decreased circulatory blood volume. There will be increased vascular permeability with escape of fluid to the interstitial space, which in turn will decrease the circulating blood volume. The heart will release myocardial depressant factor, which is released due to coronary insufficiency, leading to myocardial ischemia, and it will cause decrease in cardiac output and blood flow. There will be worsening of pulmonary hypoperfusion, formation of pulmonary edema, tachypnea, and ARDS. Anoxic damage can be seen in heart, kidney, and brain, and there will be hypercoagulability of blood, the slowing down of blood flow and thrombosis. Coming to the morphological features in shock. Shock is characterized by multi-system failure. That is, it can affect almost all the organs in our body. The major organs affected are brain, heart, lungs, and kidneys. The brain will show hypoxic encephalopathy with the cerebral ischemia. Grossly, there will be ischemic necrosis in brain. In microscopy, we can see the neurons, especially the Purkinje cells, will be affected. The affected neurons will show intensely eosinophilic cytoplasm and pycnotic nucleus. The dead and dying nerve cells will be replaced by glial cells. In heart, there will be hemorrhage and necrosis with ischemic areas or infarct in the subepicardial and subendocardial region. Zonal lesions will be seen in the heart. These are opaque transverse contraction bands in myocytes near the intercalated disc. The lung affected by shock is called shock lung. It is affected only in septic shock. Grossly, the affected lung will be heavy and wet. In microscopy, there will be congestion, interstitial and alveolar edema, interstitial lymphocyte infiltration, alveolar hyaline membrane formation will be seen. Thickening and fibrosis of alveolar septa will be seen. And fibrin and platelet thrombi in the pulmonary microvasculature can be noted. Kidneys will show irreversible renal injury in shock. Grossly, the affected kidney will be soft and swollen. The cut section shows blurred architectural markings. In microscopy, we can see acute tubular necrosis and brown tubular cast. In adrenals, there will be release of aldosterone, glucocorticoids, and catecholamines, and there will be acute hemorrhagic necrosis of the adrenals. The GAT will show, or the gastrointestinal tract will show hemorrhagic gastroenteropathy. There will be mucosal and mural infarctions. Ehrlich's ulcer is a characteristic ulcer which is seen in shock due to burns. Grossly, the gastrointestinal tract will show multifocal lesion. Superficial reddish purple ulcers can be seen. Bowel mucosa will be edematous and hemorrhagic. In microscopy, we can see dilated and congested blood vessels in mucosa, and also hemorrhagic necrosis of mucosa and sometimes submucosa can be seen. The liver will show faint nutmeg appearance, and in microscopy we can see ischemic shrinkage of the hepatocytes, hydropic change, focal necrosis, and fatty change. Coming to the clinical features, the patient suffering from shock will show hypotension or very low BP. There will be subnormal temperature, feeble irregular pulse, shallow and sighing respiration, pale face, sunken eyes, weakness, and cold clammy skin. Coming to the complications which can occur due to shock are acute respiratory distress syndrome, disseminated intravascular coagulation, acute renal failure, multi-organ dysfunction syndrome, stupor, coma, and death. Now, as we conclude, the points to be remembered are: shock is a circulatory disturbance in which there is diminished cardiac output or reduced effective circulating blood volume that impairs tissue perfusion and leads to cellular hypoxia. Major types include hypovolemic shock, cardiogenic shock, and septic shock. In the pathogenesis, there will be decrease in effective circulatory blood volume leading to tissue hypoxia and cell injury, which will in turn activate our innate immune system, which will further worsen the cell injury. The stages of shock include compensated shock, in which our body will try to compensate for the reduced blood volume, progressive decompensated shock, and irreversible decompensated shock. Shock can affect almost all the organs of our body, and the major organs which are affected by shock are heart, brain, and kidneys. Thank you.